Today's topic is the principles of adjuvant therapy of musculoskeletal. Very big topic. Today's overview of a lot of different principles in the management of bone and soft tissue tumours. So today I'll break the presentation down into two parts. The first part is the principles, and that includes our aims of what we're trying to achieve in the role of staging of muscular and skeletal tumours. Go into a small amount of detail about radiotherapy and chemotherapy, and also other adjuncts such as hormonal therapy. And afterwards, if you'll bear with me, that'll be rather didactic. In the second half, we will demonstrate a few of the principles. So to begin with, adjuvant and neoadjuvant, what's the difference? I think it's fair to say that adjuvant came before neoadjuvant. Adjuvant therapy, a strict definition being the therapy provided after the primary treatment of a condition to assess that treatment. So in the setting of bone and soft tissue, that would involve the use of chemotherapy or radiotherapy after a surgical resection, disease-free status and patient survival. And the example I've given here is the irradiation of a long bone. Improve the likelihood of Neoadjuvant therapy, on the other hand, is a newer concept, and that's giving the radiotherapy or chemotherapy prior to the surgical resection. New osteosarcoma, for example, that was discussed. Smaller resection at the time of surgery. So broadly, the steps in the management of these conditions are, first of all, to reach the diagnosis using the methods that we've been seeing over the last few weeks. That is starting with the history examination initially, and then imaging, including X-ray, CT, MRI, bone scanning. Once the diagnosis has been reached, the staging, whether it's local or systemic spread. And at this stage, a multidisciplinary team will review the case and start planning their neoadjuvant if it applies to the particular tumour that you've got. After a course of the neoadjuvant treatment, the effect of your treatment re-staging, and effectively that means going through the initial imaging and investigations again, obtaining some more tissue so you can find out just how much of the tumour cells have induced into necrosis by your treatment, and then proceeding on to a defined surgery. After the surgical resection and after you're satisfied, then go on to commence your adjuvant treatment for So multidisciplinary teams, they've been around for a while now, and they really are the standard of care for any patients that our soft tissue and bone malignancies, the components experience in management of these conditions, working closely with an orthopaedic oncologist actively involved in research in the various chemotherapy, who's tailoring your adjuvant and neoadjuvant chemotherapy. Musculoskeletal or interventional radiologist is an essential part through your imaging, and also to assist with biopsies through your predefined soft tissue. And invariably, working in the limb, you'll be working surgeons and also general surgeons I mentioned. And we shouldn't forget our friends in allied health. So when I've touched on it already, but when we're using adjuvant, and by adjuvant I mean neo and adjuvant therapy, what are we trying to do? If your tumour represents a primary malignancy, eradication is the main aim. But if this represents a metastatic malignancy, metastatic altered by this stage, and really what you're trying to do is minimise pain and preserve. And to do this, we use a combination of chemo, radiotherapy, and surgery. So I'll start with chemotherapy. Specifically, prior to surgery, we're looking to debulk the tumour to allow for smaller resection margins, meaning that any limb salvage is made more practical or more likely rather than proceeding to a full amputation. It also allows for the histological analysis, taking a sample of those cells and looking at them under the microscope, their response to the chemotherapy that you've been providing. And generally, if you're getting more than 90% of tumour necrosis, that's seen as a good. Not demonstrated, but suggested is that at this stage you're also preventing any microbe. And in this case, the adjuvant therapy is effectively mopping up afterwards micrometastatic disease after you've debulked. How does it work? It takes advantage of the high proliferation rate of cancer cells, and the agents target very different parts of the malignant cells, the DNA, the RNA, to induce a state of apoptosis. And so they can be broadly toxic to any highly proliferating cell. An example of this would be the anti-tumour cell cycle specific, so only targeting those cells which are actively proliferating. All those that can target a single phase of cell replication. An example of that would be vincristine, which targets I'll briefly touch on the four main classes of chemotherapy. There's the alkylating agents, and these use a positive charge carbonium ion cross-linked DNA, disrupted, induce apoptosis. And a common alkylating agent is cyclophosphamide. Anti-metabolites, I'm sure all familiar with methotrexate from our patients. These form a non-functioning substrate for cell proliferation. So in the case of methotrexate, it's a folic acid on one side. It acts on the ribosome during the S phase of replication, preventing any further cell replication. Another example of an anti-metabolite is 5. Because they have a higher rate of turnover. Correct. Because they're so anti-metabolites, so methotrexate, because they're so metabolically active, they're preferentially hence you see the side effects in that. Plant-based alkaloids, I've already mentioned vincristine, which is and these act directly on the proteins in the proliferating cell, disrupting microtubules. And there's also the anti-tumour antibiotics. These molecules are derived from streptomycin, and they insert in between DNA base pairs. They as Mr. Hall was alluding to, any non-tumour cell lineage, which also has high turnover, will also have complications. So this is commonly seen in the mucosa, causing nausea and vomiting, anorexia, any mucosal lining, including within the bone marrow, there's myelosuppression. And there's also longer-term complications, and they can include pneumonitis, hemorrhage, cystitis, pulmonary fibrosis, nephrotoxicity, cardiotoxicity, and with regards to chemotherapy, essentially you are aiming to get your adjuvant chemotherapy out of the way. I'll wait 3 or 4 weeks after the last dose before performing a resection, and then restart your surgery 2 to 3 weeks after surgery. And that's to allow proper wound healing, bearing in mind that as an example, here is a chemotherapy regimen which has been used by Westmead Hospital in Sydney for the treatment of children with Ewing sarcoma. And in in this first phase, the neoadjuvant phase, the main point to take is you've got alternating combination therapy. 3 weeks of 3 agents followed by 3 weeks of another 2 agents, which allows different chemotherapy agents targeting different parts of the cell cycle to attack different cells which are at different stages of that cycle. And then the resection is formed which tumours are responsive to chemotherapy. Our list includes osteosarcoma, Ewing sarcomas, malignant fibrous histiocytoma. And those are the ones in the literature for whom the disease-free periods and mortality rates are improved by the use of chemotherapy. The cytotoxic drugs aren't the only chemotherapy agents that we use. Bisphosphonate has been shown to reduce the number of, in metastatic cancer, the number of lesions that appear, bone pain, and the incidence of pathological fracture. And for metastatic cancer, which already has a hormonal response, such as breast cancer or prostate, hormonal therapy, which is often part of it, continue to decrease the rate. And I'll press on. We'll have some cases shortly. Radiotherapy, I'm sure we're all very familiar with, uses a linear accelerator to generate a very well-defined radiation beam. And within the cell, that generates oxygen-free radicals which damage the DNA, leading to apoptosis. The effectiveness depends on the stage of the cell cycle, how well oxygenated the tissue is, and the primary bone and soft tissue tumours that was responsive to radiotherapy are few, and they tend to be the bone marrow tumours, so the lymphomas, the multiple myelomas, and most the metastatic carcinomas are sensitive to radiotherapy, but not renal cell carcinoma. Specific roles within our field that we see are neoadjuvant treatment of soft tissue sarcomas, but not osteosarcoma, adjuvant treatment of soft tissue malignancy, but other requires a much more extensive requirement. Like chemotherapy, radiotherapy has its complications. Local changes include skin changes, which are along the spectrum from erythema through to fragment, and high turnover tissues are susceptible. So in limbs, we see chronic edema, pathological fractures, avascular necrosis of bone, and non-union of fractured bones as a result of radiotherapy. Here's an example here. This is a gentleman that had neoadjuvant radiotherapy for had the tumour resected and has this subsequent breakdown. Why does it do this? Well, radiotherapy distorts the soft tissue planes we operate. There's a JBJS article that made some recommendations around patients receiving radiotherapy. All in all, wasn't all that useful for the purpose of tumour surgery. They suggested avoid operating the radiotherapy field if possible. Delaying it for 3 weeks after your surgery, recommencement of therapy for 3 weeks after. And if you are operating in a field that's been irradiated, using meticulous soft tissue management, and so here's our first example of another radiotherapy complication. This is a 76-year-old man. The case was a 76 years ago and received adjuvant chemotherapy. So would someone like to describe the X-ray appearance? Very good. It's a post-radiation sarcoma or a spindle cell sarcoma. They occur in the field of previous irradiation. The histology that occurs is a osteo or biro. It's hard to pin down in the literature just how often this happens, and most papers use a catch-all statement. Incidence is related to the prevalence. But generally, it's a higher rate in those that receive chemo and high dose. So they're broadly the principles underlying adjuvant therapy. We'll move on to the case studies now. So the first one is, these are some cases I've pulled off the web. The images are a little old, but I think they'll suffice. 13-year-old seen in a paediatric clinic. Mum and dad are concerned she's coming with a limp. Night sweats and some loss of weight for the last 2 months, and there's no... these are her bloods. The main abnormality is that she's... body differentials. There's some more images. They're able to find a bone scan for this particular. I can't tell you which phase that's at, unfortunately. Yeah. This is a systemic stage. So there's no fellowship. Some quick questions. You mentioned Ewing's. This is a case of Ewing's. Is radiotherapy helpful just broadly across the room? As I understand, the location and so who was listening to my presentation? Gage, does radiotherapy help with Ewing's sarcoma? Okay, we've got Audi, we've got radiotherapy bunkers at Sunshine Hospital now. If we see that this child lives in St Albans, what do you think is the next appropriate step? Would you just call the rad-onc reg and get them to do some radiotherapy next week and we'll see? Pritinesh, I mentioned that bisphosphonates are helpful for sometimes in skeletal metastases. Would that apply to Ewing sarcoma? The main indication for bisphosphonate therapy is for metastatic. Not necessarily. So using multi-agent neoadjuvant therapy, surgery and radiotherapy, we can expect a 50% 5-year disease-free rate, 70% 5-year survival rate, but that's reduced to 30% if there's evidence. This child had skip lesions in the opposite femur, and the second case study is a 16-year-old boy who's seen in our patients. He had a sore knee for 3 months and a palpable lump around that knee for a further 2 months. And this is the X-ray of his distal femur. How do you want to do this one? Scan shows like that. I haven't included the axial sections, but yes, they did. The main thing just to take from this is so I'll ask that same question again. Stuart, is there a role for radiotherapy in osteoarthritis? Soft tissue sarcomas there is, but not for osteoarthritis. We took our, so at the time of resection, the histology was performed, and that showed that there was 80% tumour necrosis. Would this be considered a good response or a poor response? This is a poor response associated. Okay, so just to wrap up, this was a talk about principles, and so the conclusions are very broad as well. Neoadjuvant and adjuvant chemo and radio improve the success of surgical management of some bone and soft tissue tumours. Workup is all important. Diagnosis, staging, evaluation of therapy, major components of tumour management. I said mostly it's bone marrow tumours that are responsible for radiotherapy, and viewings osteosarcoma, chondrosarcoma. There are other adjuncts, including bisphosphonates and hormones.